And I was previously working in India for around 2 years. I've completed my MBBS and I'm on to for my training in internal medicine. Here I'm presenting a case that I had seen way back when I was working in India in Sarvodaya Hospital with one of my consultants, and this is known to be one of the rarest possible presentations of giant Mantoux reaction in latent tuberculosis. To start with, let's know what Mantoux test is. It's a type of skin reaction that determines whether a person is infected with Mycobacterium tuberculosis or not. The reaction that happens is read between 48 hours and 72 hours after administration of zero point 0.1 ml of tuberculin purified protein derivative. And we usually do this on the volar aspect of the forearm. Once we're done reading about taking the reading in 48 to 72 hours, we take another reading in around 1 week's time. So I'm here reporting a giant Mantoux reaction. To know what a giant Mantoux reaction is, let me tell you that while we take the reading, it is usually the erythema that is considered. So the widest diameter of the erythema around the lesion is the reading of this reaction. If it is greater than 40 millimeters in diameter, then we say that it's a giant Mantoux reaction. And there are certain cases where giant Mantoux reaction can be seen and has been reported in literature. Uh, for example, in lepromatous leprosy, because of the cross antigenic reaction. If there is high load of Mycobacterium tuberculi in active tuberculosis, that can be another area where you would see a giant Mantoux reaction sometimes. But this case is different because here we had a giant Mantoux reaction when the patient was not symptomatic for tuberculosis, which is known as latent tuberculosis. Um, Coming to the case, this is a case of a 42-year-old woman who presented with some generalized complaints like fever with chills, pain abdomen. The pain abdomen was more pronounced in the lower abdomen. She also had increased maturation for the last 4 days. Looking at her symptoms, the first differential that we had in mind was a urinary tract infection. We ruled out other causes of fever, in which tuberculosis here was also a differential for us because in India, we know the caseload of tuberculosis, so we usually try to rule it out when we have a long-standing history of fever. When we tried ruling it out, we got to know that the patient did not have any cough, no weight loss, no hemopsis, no altered appetite. We did not receive any significant personal and family history, and she also said that she's not taking any over-the-counter drug. BCG vaccination mark was seen on her left arm, and she said that she'd received it more than 20 years ago. Uh, when we take history, the next step we go to is always the examination. We did the systemic examination. We found suprapubic tenderness, which was again suggestive of a urinary tract infection, a cystitis probably. We ran some blood investigations, which included a complete blood count, kidney function test, liver function test, blood sugars, urine microscopy, urine culture sensitivity, and ultrasound whole abdomen, which again came out to be suggesting of urinary tract infection. Um, we started the patient on a broad spectrum IV antibiotic. We waited for the culture reports to see what bug was growing in the urine. When we would come daily to assess the patient on rounds, sometimes the patient would say that I have a swelling in the neck midline, which could be which could not be appreciated on the neck examination. We thought we should evaluate since the patient is complaining, and because it was a midline swelling, we were probably thinking along the lines of a thyroid nodule or a thyroid swelling. We did the ultrasound to look at the neck swelling, and to our surprise, it came out to be multiple necrotic lymph nodes in the right supraclavicular region. In view of ultrasound neck findings, we did a Mantoux test because the first differential that comes to our mind based on this ultrasound neck finding is tuberculosis. For the Mantoux test, like I mentioned, we usually take zero point 0.1 ml of tuberculin protein, purified protein derivative. Um, Again, to our surprise, the moment we were doing a Mantoux test, we observed a sudden wheal of 7 millimeters spontaneously. Usually, this wheal comes later on. The patient developed arrhythmia and induration after 7 hours following the administration. And this swelling and arrhythmia markedly increased in the next 32 hours. So after 48 hours, the picture we had was very surprising. It was a massive induration with a bullous lesion in the center, which measured 110 into 35 mm. Like I mentioned, that a giant Mantoux reaction is usually 40 millimeters and more. When we look at the giant Mantoux reactions that have been reported in literature in various diseases like lepromatous leprosy and high active tubercular load, we've seen giant Mantoux reactions measuring around 60 mm, 70 mm, but nowhere around the lesion that we observed, which came out to be 110 into 35 millimeters, specifically when the patient had latent tuberculosis, which is asymptomatic in the first place. You can see from this, we've applied some lotion on it before taking the picture because there was marked erythema. But if you look at this, there's significance surrounding erythema. When we measured the greatest diameters of the erythema surrounding the bullous lesion, which is in the center, it came out to be 110 millimeters in 72 hours duration. To investigate further and to confirm, because the confirmation would have been through an FNAC of the lymph node. We did an FNAC, which is fine needle aspiration cytology. We saw granulomas with fast acid bacilli, which was confirmative of tubercular infection. To look at the other sites, which included pulmonary tuberculosis and other sites of active tuberculosis, we did a CT thorax, we did a fundus examination, and everything came out to be normal, which confirmed and reinforced our diagnosis of latent tuberculosis. Once the confirmation was done of latent tuberculosis, we started the patient on anti-tubercular treatment because that's what the guidelines suggest. Even if the patient has latent tuberculosis, it can anytime progress to active tuberculosis if the patient's immunity dips down. And also that the patient can go on to develop pulmonary tuberculosis and can be contagious and lead to widespread community involvement. So we started her on anti-tubercular treatment and patient was discharged with advice of close follow-up. We called the patient for follow-up to look at the lesion as well. And again, to our surprise, it ulcerated after 2 weeks, which is again a marker of high tubercular load. It gradually disappeared after 2 weeks. We saw that we kept the patient on follow up for ultrasound next, and we saw that there was a regression of the lymph node in 2 months of initiation therapy of anti-tubercular treatment. After 2 months of initiation therapy, we shifted the patient on maintenance regimen, and the patient remained asymptomatic throughout the course for tuberculosis. I have a picture of how it looked like after a 2 week on follow-up as an outpatient. You can see that the erythema and the swelling had significantly settled, and all we could see was an ulceration as compared to the previous lesion that had marked erythema around it with a bullous lesion in the center. Um, Conclusion being that first, treatment of latent tuberculosis is very important. Secondly, giant Mantoux reaction can also be seen in latent tuberculosis, which is a very, very rare presentation, and we hardly have any literature on this as of now. Thirdly, a lesion as massive as 110 millimeters can also be seen on latent tuberculosis. If treated on time, this can stop the progression to active tuberculosis, stop the progression in the community, and can lead to complete regression of the disease in an individual. Yeah. May I please request you all to put your questions in case you have any? Thank you so much.